การดูไลฟ์สตรีมมิ่งนะครับเราจะมีการถ่ายทอดสดจากในห้องของ OR ซึ่งจะใช้ห้อง OR เนี่ยจะอยู่ที่ตึกข้างๆกันนะครับอยู่ที่ชั้น3เนาะของโรงพยาบาลแม่ฟ้าหลวงแล้วก็เราถ่ายทอดสดกันมาที่นี่นะครับเราจะมีการให้พักเบรกนะครับช่วงประมาณ 11 โมงถึง 11 โมง 15 เนี่ยเดี๋ยวเราจะจัดในส่วนของรันบ็อกไว้ให้นะครับทางอาจารย์สามารถรับประทานอาหารมี3เมนูด้วยกันเนาะแล้วก็สามารถเอามาทานข้างในห้องพร้อมกับดูไลฟ์สตรีมมิ่งกันได้เลยนะครับโอเคงั้นถ้าไม่เป็นการเสียเวลานะครับเดี๋ยวผมจะขออนุญาตกราบเรียนเชิญท่านดร.ไพศาล ลำมณีธรนะครับเป็น Director of แม่ฟ้าหลวง University Hospital ครับขอบพระคุณครับ
ครับก็ I would like to as we have Dr. Kai here I would like to conduct in English so good morning I'm Dr. Paisan I'm in charge of the dean of the school of the anti-aging and the director of the hospital as well so today is quite a good opportunity that Dr. Kai Dr. Oliver Kai our famous renowned plastic surgeon will gonna give us the lectures about this body jet system for harvesting the fat and also reinjection into the breast. And we would like to also thank you for the Technicalbiomed that cooperate together to set up this venue for this short course today. After all, we will have Dr. Kai give the lecture to us. One thing is, in terms of the learning, liposuction for us in Thailand, we can do for the doctor. We don't have the restriction. But you need to do it well, need to do it good. So you need to have the study or the learning curve for yourself. 5 years, 10 years. I have trained for 500 doctors to do the liposuction in Thailand, and some of them are going quite nicely for his practice. So I would like you to learn, and anyone who have the experience, Dr. Alex, we can share the knowledge together too. So welcome to our school and studying today. Thank you.
ขอบคุณมากครับท่านดร.ไพศาลครับครับเดี๋ยวช่วงเวลาต่อไปนะครับเดี๋ยวเราจะขอเรียนเชิญท่านดร.คายโอลิเวอร์คายครับเป็นการให้การบรรยายในครั้งนี้ด้วยครับขอบคุณครับได้ครับ
I would like to introduce our great speaker, Dr. Kai Oliver Kay. He is board certified in plastic surgery, and his practice in Spain mainly and in Zurich as well. He get his medical degree in Munich and continue to study in Los Angeles and also in Paris. Now he's a renowned speaker for many international speaker and also the member of various international society. Dr. K used to be with us 2 years ago, 2017, for the as an invited speaker. So please give a big applause and welcome Dr. Kai.
So, thank you, and I'm always happy to visit Bangkok again, a city which I appreciate a lot. And I'm happy that I see so many people interested in learning something on those techniques, what we can do about liposculpture and lipotransfer. I'm going to try to make this lecture in a way a little bit interactive, so if you have questions in between, there's no problem. You can ask and you should ask, okay? We have time enough to do this. In a first step, I'm going to give a lecture which shows a little bit the technique and what we can do in general. We're going to show you some photos of the patient we're going to operate in the second part of the surgery. So in the morning we do the theory, and what we learn in the morning we'll apply to practice in the afternoon. This is our patient, which we are going to operate later on. We're going to perform a liposculpture of the abdominal outer hip area and do a lipotransfer to the breast for breast augmentation. I think for all of you, this is a very interesting kind of patient profile because these are patients who have a wish for breast augmentation. They maybe don't want to have implants, or implants is not what you can deliver as a practitioner, but you can do fat. It's a surgery which has a very good risk profile in general. It can be done under ambulatory premises and as a solution. In most patients, this can be performed as well under local anesthetic, which is very important. You have to choose the patient well. That's the only thing. The patient needs to have enough fat, point one, and the patient needs to have a skin which has enough laxity to get the fat back in when it comes to the breast. If you're going to try to have a very thin patient, a very young patient with a tight breast, at the end your results will not be good and the patient will not be happy with the procedure. So patient selection is number one in this kind of procedure. But a patient like her, you can see, she has a, do we have a laser pointer here? Okay, we can see here, this is not a, it's not an obese patient, but compared to the rest of her body, we have a good amount of fat. So when it comes to the markings, the first thing I do is I do like what we call a topographic map. So you have to imagine when we do water jet liposuction, it's a little bit different than tumescence liposuction. The classic way of tumescent liposuction is you're flooding the whole body with a certain amount of liquid, and then this liquid stays in, you wait a certain time, and then you start suctioning. Here we do different. We only pre-infiltrate a little bit of liquid, and then during the act of harvesting the fat, we're adding new tumescent solution all the time. So it is important that you mark here, like you see a little bit in a topographic map. We lost, I think, the... Okay. You have to mark like the valleys and the hills of the area where you go. Because if you imagine with your cannula, once you have infiltrated liquid, the anatomy is not the same like in the patient before you start. So evidently all those differences where the tissue is thicker and less thick, you have to mark before. So if I mark here, as you can see here, you can see this is an area where compared to the area on the side, the liquid is, the point is maybe thicker than in the area around. The red dots, what you see, these are the points where the tissue is the thickest, okay? So these are the points where I want to do the most harvesting during the point. What you need to do is, what you want to avoid, and the most important thing is leaving sequels after the liposuction. So if you remove too much fat in one area, you will leave an indentation, okay? And it will be visible. So you have to start basically with the areas where you find the most fat, and then you, from this area, like from a mountain, you feather out to the areas which have less fat, okay? So until you reach the point of how much volume do you need. Now, the question is, how much volume do we need for breast augmentation? This depends on two factors. First of all, the fat which is available in each patient. You will have some patients which maybe only have 150, 200 cc per side, so a total of 300 to 400 cc to take. A patient like this, you can take a little bit more. That's one side. And the second point is the limitation of the recipient area. That means when you have a young girl, the breast is very tight. She maybe have a, what we call a constricted lower pole. That means here the lower part of the breast where you have the fold is very tight. In these patients, in one session, you will be very limited in how much volume you can put in because the fat cells are living cells, okay? So it's not like you take a big bag of stones and put them all in. No, they need to live. So they need space in between them to survive. And during the first 3 weeks, while the process of neovascularization takes place, the blood vessels need to grow in. And for this time, you need to respect that these cells need a certain tissue matrix in between them for the diffusion to happen. If you put in too much, that means if you fill the breast too much, you will lose all the fat. So it's a very important thing. There's an end point, and I'm going to point out in the surgery this afternoon how you can find out about the end point of tissue tightness. Okay, so you need to control tissue tightness. So you have to inform patients who want to have a little bit more breast and who are very tight that they may need more than one procedure. So you do one fat transfer, You transfer the cells, you wait 3 months. In those 3 months, two things happen. The skin envelope stretches because the fat cells are growing in, and due to the effect as well of the stromal vascular fraction stem cells in general, the skin loosens up a little bit there. So we can use this as a step procedure as well. And in my opinion, you can achieve with a single transfer, you cannot achieve more than a cup size maximum, okay? If a patient wants more than a cup size maximum, you have to tell them you're gonna have 2 or 3 sessions. If there's enough fat, you can do this. You don't take all the fat, you do the first session, you take 200, 300, you wait 3 months, you do a second session or a third session. And each time, fat grafting is an additional procedure. So you have to imagine, all of you know that when we do fat grafting, we lose a certain amount of cells in the process. These are living cells. So basically, of the amount of fat cells which are put in, only around maybe 60, 70% will survive. 30% in the process, they die. They're going to be absorbed apoptotically by the body, and they're going to be washed out. There's no problem if you know that, because if you say if we transfer 200 cc to a breast and we say 150 cc survives, that's okay. That's already a difference. But you have to explain the patient that to avoid that they're going to be disappointed, you have to explain they're going to have the first months, they're going to see themselves with a breast they like very much. And after the first month, they will say, okay, it was more before. So you have to tell them they're swelling, and it's normal that a part of it disappears. And that's fine. I think from the painting, this is clear. So when it comes to the patient, the only thing what you have to check out with them, from my experience, to have a good result when it comes to patient selection is smokers. When you operate on strong smokers, fat grafting does not have good results. And that's very easy to understand. The survival of fat cell depends on diffusion. Smokers have a vasoconstriction, and there's not enough blood flow, and the fat cells don't take very well. Okay, that's the only really limiting factor. Apart from these, it's a procedure which you can use at every age and basically at every patient type. Are there questions regarding patient selection so far? Okay, then I would say we're going to start with a lecture.
Yeah, you can continue.
Perfect. You go with a slide or?
Yep, your slide. Yep.
You can slide? It
Yep,
works
you
with
can
this?
slide.
Okay, perfect.
You can type.
Yeah, perfect. Okay, you can take photos, no problem. The only thing, if there's some patient photos, facial photos, please don't take photos from the facial photos, okay? My unit and I, we've done a lot of publications on waterjet, use of waterjet in different kind of surgical environments, being in facial surgery and body surgery. We're going to limit this today more on the body type, but in general, it's something which I do since now more than 12 or 15 years almost, and I think it's a great technique which has a lot of advantage when it comes to adding to your surgical practice something which has to do with fat transfer especially. So for a quick question to the audience, who has already worked with BodyJet here? 1, 2, 3. Okay, so I would say maybe 5 to 10 people. So for the rest, I'm going to start to explain a little bit what's the concept of it. Normally when it comes to liposculpture, the concept of liposculpture is a very antique concept we're going to see later on. It's a concept where we remove fat cells over a cannula and we're using suction to take them out. When it comes now to waterjet, the whole concept goes a little bit further. The idea of this was, instead of having a static sitting solution, which we infiltrate before the operation into the body and then wait, we're infiltrating at the same time that we're aspirating. That means the cannula we're using has inside the cannula another tube, which is a jet tube, which you can, with a pedal, inject liquid during the whole time of the liposuction. So it works a little bit like when you imagine a pressure cleaner, okay? So you can use this, the force of this water jet in two things. First of all, to open the tissues, because when you move the cannula and you use a water jet while you're moving the cannula, evidently the water opens the way for the cannula and you don't have mechanically press it through, so it makes it a little bit less painful, less invasive for the patient. And the second thing is the water flow. You can then use that the water cells, they don't return dry in the cannula. They return with a lot of water, which makes that they're more protected. The idea is, when you imagine a fat cell can only survive if the membrane, the cell membrane survives. So we have to avoid two things. We have to avoid shear forces, that the fat cell is kind of bent and pulled, and we have to avoid pressure. And by doing this, when we do the water jet lipoharvest, we're lowering the liposuction pressure, and we're using the water to really wash out the cells. So it's a high pressure water jet. We're using a limited negative pressure compared to classic liposuction. When you just want to throw the fat away, you would use higher negative pressure, but we're limiting the negative pressure to 500 millibar if we extract fat, which we want to use. And we do this in a closed system, which is an integrated infiltrated suction system. This is a small machine. We are going to use a bigger machine that varies on the market. This is how the cannula looks like a little bit. It's a fine cannula. At the end, when you push the pedal, a spray comes out, and this spray does two things. It disperses the solution into the body. So I made a study on this on a facelift patient on using manual infiltration. That means with a syringe and just a cannula infiltration, the tumescent solution, or using the machine. As this is a dispersed spray, the tissue penetration is higher. So you get a quicker onset of the medication. That means we use in the tumescent solution, we use lidocaine and we use adrenaline. The adrenaline to create vasoconstriction, so to get less bleeding, and the lidocaine for pain management. So compared to classic infiltration, when we use a water jet, as the water is not, like say, injected as a fluid, but more like a spray, the penetration into the cells is quicker. You have a quicker onset of hemostasis, and you have a better pain management. I could prove that. This is in the point of, but I think, let me see. Can you go to escape a moment there?
Forward?
No, just go here. Because I think you opened. That's the same. So this is the second one. If we have time, we're going to go in the other one. The other presentation is more focused on facial one. As we start with body, I'm going to go on the body one here. Okay. A little bit of information as well on liposuction as a procedure in the body, which is very important. Human nature always wanted to get rid of fat. It's not something which we invented in the last 100 years. So this is a very funny citation which I found in an old book from 40 before Christ, where something says fat was withdrawn from Apronius and his body was relieved of the weight that made it impossible for him to move. So the desire to be less fat dates back thousands of years. It's not something new. So I think it's something which we're always going to find. When we come to liposculpture, modern day cannula concept, it's a 20th century concept. This guy, and this is very often like this in history, this guy was the first guy who really took fat through a cannula as a modern kind of cannula-based liposuction. Unfortunately, his model, the first patient, died after the surgery. So all his colleagues say, this new technique, it's not good. It was not the technique, it was like very often more the way how we apply the technique. The technique itself was fine. The guy was maybe just unlucky. But I found this photo in one of these French archives for surgery. But due to the incident, the cannula concept of liposuction through a cannula was pushed back another 50 years. So that's very often in life like this. Then in the 60s, where really, again, interest came out to do this, two guys reinvented again the idea, which they've read about, how to do that. And there again, these were not plastic surgeons. These were two gynecologists from Italy. And they came to the idea that this must be possible because they used a tube for their obstetric operations to aspire material from the womb, yeah, to aspire in female patients to do a kind of cleaning and things like this. So they said, if this works on the womb, why should it not work with fat? So they used a motorized scalpel blade into this. It was very traumatic, but it was the first way of new liposuction through a rubber tube. But it wasn't really refined. And now these are the only two which for modern liposuction you really should know. This is Ilou and Fournier. They then afterwards retook, these are two plastic surgeons, they retook the concept in the 60s and they're called the fathers of modern liposuction. So now, we're going into the year 2020 almost, and we're much bigger in technology than we were a couple of years ago. Like I explained with the slides from before, this fan spray, which we create with the machine, has two basically main goals. One goal is to facilitate a good hemostasis and a good pain management. The second thing is an opening of the tissue, that when you move the cannula forward, that you don't move the cannula just with your basic force of your arm, but that the water jet for you opens the tissue a little bit, okay? And the idea is, you've always done this. Now imagine you have an area where you have a lot of structures, tight ligaments, fibrous structures, vessels, nerves. You try to move something around this in a dry state. You will find this difficult, and B, you may lesion other surrounding structures. If you now add water to it, everything becomes movable, and that's a little bit the idea. You're moving in a so-called liquid state, okay? And as you have not water everywhere, but you're moving a cannula which is spraying the whole time, you can take this liquid state with the tip of your cannula. And that's the main difference to classic tumor sense technique. I show you here the basic principle, how it works. The cannula goes in, you go forward with the spray to really make the way, and then two things happening. The fat cells, first of all, they will swell because the tissue will penetrate the membrane, and the fat cell will swell a little bit, and apart from being swollen, it will be taken out of the surrounding compound. But you see that the ligaments and the vessels, they stay more or less the same, okay? And you can see here, very important as well, where do I suction mostly? You can see here there are two layers. There's an interfat membrane, okay? This is what we call the fascia, interfat fascia, and we have a superficial department and a low-fat department. Very important is when you aim with your cannula to get good and very neat results with little deformations on the surface, you should try to limit your liposuction on the lower department of fat. Because if you empty out the upper department of fat, you're creating basically what people have when they have cellulitis or everything. You will create depressions and dimples and all those things. And you're taking the tension away on the skin. So these compartments, they give support to the septums which go to the skin. If you empty out these compartments, the septums stay, but the skin loses support, and you're creating like an orange peel effect. So you should always limit yourself to the lower part of it. The basic symptom is this. When you look at this under electronic microscope, when you use the water to open up the membranes, you can really see how the cell membrane is split up using the water jet, and so you have a separation of cells from the surrounding tissue by this water jet. You can adjust the spray, and this is important in some areas where you want to, for example, when we do lipo-harvest, compared to the fact if we just do liposuction, we want to throw the fat away, you can use a higher range of water jet. If we do lipo-harvest, as I said, I want to damage the cells as less as possible, so I use a lower mode, okay, and on the machine for this. And this then allows me to give a higher yield of surviving fat cells. There are many different ways of do liposuction. We're going to speaking about water assistant today. Just to know, many of you have heard of the other ways, standard liposuction, power assisted, ultrasound or laser assisted, all these are in. Big difference now is you can see here on the left side, this is tumescence technique, And on the other side here, this is a water jet technique. So water jet is not a tumescence liposuction. It's very often mixed up. The concept is different. When you do tumescence, you inject a lot of fluid before, you wait, and then you suck. This has disadvantages. First of all, you see the anatomy is completely distorted. You cannot really see what you're working on. Second point is, in more obese patients where you want to take a lot of fat away, you're very much limited through lidocaine toxicity because you have to inject a lot of fluid before. Yeah? While when we use VAL, the remaining fluid that's in the body and that can be absorbed by the body is much lower. So lidocaine toxicity is much less an issue using VAL technique than tumescence technique because the time of the fluid being in contact with the cells is much shorter. You inject, but at the same time you aspirate. It's a circle all the time. So when you look at studies, the lidocaine levels in bloodstream are much lower in VAL technique, which is an important safety feature compared to tumescence technique, especially in bigger volumes, not for smaller volumes, but for bigger volumes. Okay, you don't have a waiting time. Classically, you need to wait. This is due to the fact what I told you, that classic infiltration works on a water-based cannula. You have a cannula with holes. You inject this, and then the water seeps into the tissue. And the water, which contains adrenaline and lidocaine, needs to be absorbed by the cell. When we use a spray, this penetration is much quicker. So instead of waiting 20 minutes, normally with 5 minutes, we can already see on the skin the effect of vasoconstriction, and we can start the harvesting. Okay? Less amount of client solution, in less time in the system, with less explanation time and less systemic resorption. And we spoke about the lidocaine toxicity. And this is an important factor for all of you who want to use this technique on patients without having the possibility to doing anesthesia. If you use a technique right, you can do this very good under local anesthesia. When I see if you use the technique right, and I'm going to emphasize on this when we're doing the practical part later on, you really need to use the machine with all the advantages it has. I've seen many doctors when I'm giving courses in the world who are using the machine because they used normal liposuction before. Now they then buy the machine and use it like the same. It's not the same. You really need to learn how to take advantage of the technique and using as well the spray. If you don't use enough of it, you're using basically a classic cannula. If you use too much of the water, on the other hand, you're getting very slow, and how much you're going to not harvest quickly enough fat, okay? Because you're going to have a lot of water in your canister, okay? There's a study here in aesthetic plastic surgery in 2007 which shows a little bit that the patients indeed have less possible bruising and hematoma, and they have less pain and a quicker recovery when you use VAL compared to standard aspiration liposuction, okay? The graph is showing basically patients free of pain between 3 hours and 14 days after liposuction, traditional versus VAL, and you can see that after 4 days in VAL there's no pain anymore, while in traditional there still is. As a scientist, I tell you, this is a good study. Evidently it's an individual-based study, but from my experience of doing 10 years now use of this, at least in hematoma and in swelling, you achieve patients who have a much quicker recovery in comparison of those two techniques. Pain is a very, very individual thing. You have patients who have no pain after a day, and even after water jet, you will have some patients who after a week say, doctor, it still hurts. But in general, if we connect the point that the key factor to pain post-operatively is swelling and bruising, so if you can diminish swelling and bruising, you will diminish definitely the pain. Okay, in structural fat grafting, when we use the VHL, we will use the system like we said. We use a closed system to avoid contamination. That means the fat comes out of the patient in a closed system in a collection canister. This collection canister is a harvest system which filters the fat. This is a pre-filter and then a second filter, and then we can take the fat on the lower part back out. I'll show this later. We're reducing the risk of contamination And on the second thing, we, at least for the body procedures, we don't need any centrifugation. That makes the procedure quicker, and we have a very good fast turnover time. Where do you can take the fat from? Basically, you can take the fat from almost every body area which is available. Sometimes in patients who are thinner, who don't have a lot of fat, you may have to add several areas to get the desired volume you need. For example, if you need 500 cc, 250 each side for a breast, and you see there's only a little on the abdomen, there's a little bit on the knee, there's a little bit on the hip, you can add them all together, okay? So we do then what we call a multi-site harvesting, and you get together to get having enough kind of. These are just some examples here. You can do everything. I mean, this is water jet assisted liposuction used as a high definition liposuction. Really, some patients want to have a definition of the muscle to really see her their kind of distribution of the muscular. We can achieve this with this technique. I use this is in combination with an abdominoplasty. We call this a lipoabdominoplasty. So first I do water jet assisted liposculptures. We call this 360 degree. That means this patient is really completely sculpted all around, and once it's gone, then I remove a little bit of skin on the top to achieve the effect. And you see it's an incredible change which we can achieve of body shape by using those two techniques together. Okay, you can use this as a pure lipo harvesting on the abdomen, thigh and hips, where it's a very good technique to do. Just some example. And you can see even in patients who have not a lot of fat, like here, you can still achieve a big change regarding it. And I think in these kind of patients, there's a big advantage of using water jet to classical liposuction because you have less risk of creating undulations. It's very hard when you, a big patient is easy to do liposuction. Your margin of error, which is visible on the surface, is big. If you have a small fat layer and you don't get the right plane, you will see an irregular result, and this is easier. We'd use it in male patients. Gynecomastia is a very nice treatment as well. These are patients which you can treat very, very nicely with a body jet and without doing, this is something which you can do very nicely with local anesthesia, okay? It's a patient, many middle-aged men have the problem of a small breast due to lifestyle, alcohol, and all those things, and it has a very quick fix solution of using this. You can see here nicely how this area is reduced, and okay, this is outer thighs, gluteal region, shaping a body from a more pear-shaped to more straight kind of body feature silhouette. We use it as well a lot of the knees, thighs, and calves. So in Europe, our patients are normally not like you Asians here, very slim, so they're a little bit more wide. So especially women desire to have thinner legs. So we use it a lot for leg sculpturing. I was asked from the organizers as well to speak a little bit about BBL. I don't know if you heard about it. It's using fat not for the breast, but as well to augment the buttocks. I'm not sure that this is, or how much this is here in Asia become a fashion. In Europe, it has become a big fashion. In US, so women desire to augment their buttocks quite a lot in different ways. So either in a way that they say they want backward projection, or, and this is a fashion a little bit which came a little bit from the US, of giving this really curvy S-shaped hip, so having a very, very tiny waistline and then going out. I'm not sure This is not my home market here, so I don't know how much the desire is here with you for people of having this. But if you want to have, and this is a good patient to show this, if you have a patient who is middle-aged where the buttocks has become a little bit softer and the patient has some fat around the midriff, it's a very good technique to use this fat to augment, like you can see here, this is 200 cc in each buttock, and it makes a very, very nice difference in the way how the buttocks look. So you can use fat as well very, very nicely to beautify. I'm not even speaking, you can see here in this case, this buttock is not much bigger than this, but it has a better shape. So very typically when we age, this area here, the trochanter area hollows out. We get a hole there, which makes then on the other point, on the top of it, something, a fat pad remains. It's called the muffin top. It's called by the Americans. And then we get a shape which is not like this classic S shape anymore. If you then afterwards take away fat from here and here and fill this middle area like we've done here, you're creating again this very nice shape of the body in the silhouette. So it's a very good technique to do this on the side without using implants or anything else.
Dr. K, for this kind of case, still, I mean, it's quite getting popular. So do you just remove the fat from the lower back and then re-inject back into the hip? So how much amount about for the fat that you do in that case? And also from the front now in Thailand, we have a kind of a sexy line, as is to more S-curve line.
I mean, to explain a little bit for the public to get it on, the S-curve is called, it's a concept of antique sculpture classes, where when they were sculpting the figures, you know, the art figures, they always sculpted them in a like a lazy S shape. So from the side or from the front, the body would do curves. So the idea is, and you can see this a little bit, when it comes to enhancement, when we use fat transfer and liposuction, the secret inside is not so much how much you take away, but it's how much you add and how much you combine the concave and the convex areas. That means our eye judges beauty by curves, because everything in nature is curves. So when we look at an aesthetic pleasing result and we dissect it, we identify it, we will mostly find that the base behind it is based on a relationship which is most in everything a relationship which is based on the circle. Okay, so the number of phi inside reflects in nature and reflects in beauty. So when we have straight lines or lines which are kind of out of the classic curved way, they're less pleasing. Like here, where you can see we go in, we go out, we go in again. It becomes to be much more pleasing. When it comes to volumes for bum, evidently it's a little bit bigger than for the breast. So you need around 400 to 500 cc per side to achieve something nicely visible as a result. But in most patients, because you double as well the space, when we do only breast, we just take the fat from here. When I do a patient like this, the liposuction as well includes this area here. So I'm adding those two areas to the harvesting side, so I normally get very easy to get 400, 500 cc per side. And I think it's something which, if it's not yet there, it's for sure something which will come as well to Asia, because like with all of the trends a little bit, we've seen this coming over from US to us over the last 5-6 years, and it's still growing, and especially in Europe. Even in the United States, the desire for this has become almost the most demanded plastic surgery procedure in the US over the last 2 years. So there is space to grow. Here, something very, very important. When you see this, and here we're speaking of the S-curve, or in general the beauty curve. When you see here, we have fat here. That means we have a hip, which is, we have a waist, sorry, which is wider than the hip. and this looks strange. Okay, it doesn't look beautiful, and on the other side, it masculines a body in a woman, because when you look at a man, we have straight bodies. You should avoid, in any case, if you treat men, to make them a waistline. It looks funny as well. So, in general speaking, here, the only thing what we did is we created a concave space here and here, and we created a convex space here. And by doing only that, it changes completely the way how this looks. And it's the same thing here. By removing the fat in the deep compartment here and adding it here, you're enhancing the shape to here, and you can do something, even with little fat, something very nice. So now we come to the thing what we're wanted to discuss for today. We have a lot of patients, or I have a lot of patients, who nowadays don't want implants. This has many reasons. Reason one, an implant is maintenance, so when you get implants, you need to be aware that maybe in 10, 15, or whatever years, you need a reoperation, you need to change them. They may get into a way of doing diagnosis like mammography or whatever, so some patients just say, no, I'm not fancying implants. So for those patients, if they have realistic expectations, fat grafting is a really good option. Realistic expectation, what does it mean? Don't operate a patient for breast augmentation with fat when they come to you and show you a photo of a model which has implants, because you won't achieve that, okay? What you can achieve is that, which I think, in my opinion, is a decent change. This is a small change of 1 cup size or something. It looks a little bit more. It is the same shape, and this is something very important which you have to explain your patients. With an implant, I can alter the shape of a breast. Why? An implant is a structural device. It's a device which has rigidity, it's a device which has projection, and if I put it in the right place, I'm changing the shape. Fat is soft. Fat hasn't got really structural G-force. So when you do fat, you can see this in this case very nicely. The shape is the same. It's just expanding in a 360-dimensional way. So you have to make your patient understand that you cannot create like an upper full, top fullness like with implant, but what you can create is a very natural, nice-looking breast. What you can create as well, this is a case, we call this a tuberous breast deformity, something very typical. Many women have this. This is a deformity where the lower pole is not really expanded, and the gland is kind of prolapsing through the areola outwards. This is why it looks like it comes outward and forward a little. You can see this is really pressing out of the areola area. Due to the constriction of the lower pole, that means there are bands here, ligaments, and these ligaments are compressing the breast towards the chest wall. And this compression makes, like when you compress a bag, that the breast tissue is pushed out of the areola, and this is why it's hanging out here. So what you can do, and you can see this here beautiful, I fat grafted the whole lower pole here. 2 things happen then. What I explained before, after 3 to 4 months, the fat graft will act like an expander. So the constricting ligaments here are expanded, and as soon as the expansion has ended, you can see the prolapse of the gland has gone back. The gland is not hanging through the areola anymore. And this is due to the point that you really made space by using the fat. And you can see here, this is a good change. And now the examples, you can correct asymmetries as well. And this as well, you see big areolas. Here in this surgery, we combined basically retraction of the areola together with fat grafting. I use this as well in combination. This is a patient who had implants before. She didn't want implants anymore. So I took the implants out. I did a small uplift, and you can see it is not so much difference of a size, okay? Size-wise, she's maybe 100 cc smaller than she was, but the rest, what she has now is fat. So you can replace implants with fat. This is as well a quite nice thing. When it comes to survival, we can show very nicely on long-term MRI scans that we're going to have a very, very nice survival. Let's go back here a moment. Here, when you see here, this is the expansion of the tissue, thickness of the tissue, and you take picture before and picture after and take the corresponding MRI scan afterwards, you can really see that this living tissue expanding, okay? So people always ask me, okay, fat grafting, does it last? How long does it last? Patients want to know. Evidently, aging contains to a certain amount as well tissue loss, especially when we think about the face, okay? When we do facial fat grafting, after a couple of years, the face will age again and use some volume more, so you may readdress. But when you do breast fat grafting, after the initial period, which is 3 to 4 months, where the fat cells need to grow in, where you're going to have some loss due to tissue survival, you will have a quite regular result, except for the case that the patient loses weight. If you do a fat transfer to a patient who weighs 50 kilos, then the patient loses 10 kilo, you must be very aware that what you transplanted is fat, so the result will disappear. And you have to instruct your patients that after the surgery, they have to be on a normal caloric diet. They should not hunger themselves down. And on the other hand as well, they should not as well start now to eat very extremely, because I've seen this as well. If a patient puts on weight, I've got some of my patients which come back after 3-4 years where I did breast augmentation with fat, and they're a cup size bigger because they chopped out a total. Okay, mostly they don't complain about that, but it's something very important to say. It's not a static result. It's fat, so it will behave like the rest of the fat of your body. And you should explain your patients that they should treat it and see it like the rest of it. This is a patient like the one we see today. Okay, this is why I chose this here for the presentation. This is a patient which I operated in China on a tour like 2 years ago, as well, just with local anesthetic. And this is to show, this is like 3 hours after the surgery. Okay, and you can see the patient has not a lot of bruising or something. We harvested, same thing like we saw with the patient which we're going to see today in live surgery. We harvested the fat from the abdomen and the waist and the upper abdomen, and then we made our drawing on what we could do to beautify the breast. And you can see a little bit here, I marked the point where I wanted to do difference. You could see here, for example, this patient had an emptiness behind the areola, which I marked, which I did a little more on this side. We worked, I marked this as well on the preoperative marking today. This is the old breast fold. You can see here breast fold 1, breast fold on the other side. Very often women have an asymmetry of the height of the breast fold. So the first thing what you need to, when you do breast augmentation with fat, the first thing what is you need to mark, you need to have your patient and you have her with the hands up and you mark the height of the original breast fold. And then, as you can see, this breast fold was lower than this one. You mark the other breast fold on the other side, the breast fold you want to achieve. Because mostly when you have different breast folds, this is associated with slightly different volumes and different expansion of the lower pole. So this lower pole on this side needs more fat than this lower pole on this side to achieve this result. Okay. This is a side view, and I think this is a decent result without implants. Okay, this is what a small lady like her would be quite happy of. Evidently, this is right after surgery. You can think she will lose around 30% of this volume within the next 6 weeks. Okay. But this is how it should look at the end of your procedure. It should not be too bruised, it should not be too ill. The patient should be standing comfortably and be able to go home. Okay? And the last thing I wanted to show you as well, if this is an issue, you can use this machine as well for sweat gland removal. And this is something which I use it very nicely. It's another indication to use this. And you go under the skin and really scrape, and by doing that, you can diminish sweating in patients who wish those things. Okay, let me wrap this together. We can use the water jet assisted lipotransfer as a way of body shaping. We can use this for the gluteal area to achieve an S-curve, to achieve a more sexy or more voluptuous body curve. We can use this for breast augmentation. We can use it very much in the face as well. If we have time later on, I can do a presentation on the face as well. It's a modern method which allows us for body shaping without using implants. It's a good alternative, especially for people who are not working in a hospital environment as a plastic surgeon. So it expands a little bit the spectrum what you can do in a more, let's say, in a more clinical way. It has a certain learning curve, so it is important that you spend some time maybe with somebody who does this on a daily basis. Maybe you ask him to give you some advice on this kind of techniques. And it's a very safe procedure if you carry it out properly. That means the risk of a small volume liposuction, and we consider small volume liposuction when we speak about 300, under 1 liter is considered a small volume liposuction. So systemic risk of a small volume liposuction is very low. The risk of damaging and harvesting is very low. So it has a good safety profile. Still, paramount is patient selection. So you need to select patients with enough fat. You need to select patients with realistic expectations when it comes to the way how they want the breast to look. Okay? And then you have to train the way how you perform the technique to deliver this without pain for a patient if you do it under local anesthetic. Because I'm going to emphasize on this when we do the practical part, the way how you move the cannula, how rapidly you move, and how in the way of how much water you use will be making a big difference if this is a good experience for the patient or not, especially if you limit to local anesthetic. Okay? It's a 3D concept, so it is as important where you take away as where you add. So you have to look at, when you shape, you have to look at it in a way that you not just say I'm eliminating fat, but you look at it in the way as I'm adding and I'm subtracting. And in the way of adding and subtracting, I'm creating my shape. Okay? And that's it, basically.
Thank you very much, Dr. Kai, for the very fantastic presentation. Do we have any questions from the floor? Yes, please.
I'm confused when you compare the orientate technique to tumescent technique.
Yes.
Because don't we also need to intake tumescent before
Yeah.
we do that?
But the word is tumescent. We need to inject infiltration fluid before. The definition of the word tumescence means that you inject so much liters of fluid that you get what we call a tumescensate. Tumescence means when you really push up volume on the skin, that you get a ballooned out body. This is called tumescence. There's a little bit of kind of, let's say, lapsus in the word, because in classic liposuction, this was always tumescent liposuction. So people would define between wet, hyper wet, or super wet, which referred of how much liters of liquid you would lose. But this was all tumescence. Tumescence means make the tissue really wet, okay? But you would, in general, inject a liter or 2 liters for an area like this and then wait. When we do a pre-infiltration, and this is the correct word now, what we do with a body jet, we're injecting very little fluid, maybe 400, 500 ml, okay? And that's it. So, and the big difference is there's no really waiting time of 20 or 30 minutes. It's normally injecting within 5 minutes those 400, 500 ml, which is just to getting a pre-plane of water, and then you're using the machine with a spray all the time. So the big difference is the amounts of fluids and the waiting time. So tumescence in a classical definition means of flooding all the tissue with a solution and then waiting. And we don't do that. We do a pre-infiltration.
So this is the way that we spray and then we extract the fat at the same time. It's not the same as a tumescent that we inject, and we need to wait for 30, 40 minutes in order to numb, to vasoconstrict. But there's a small amount, and then we inject and then extract the fat simultaneously. And one more thing that I would like to emphasize is, as Dr. K talked about how to extract or harvest the fat, we need to go both the upper and the superficial and also the deep part of the fat. And when we re-inject into the breast, also we need to distribute it small amounts, small aliquot, homogeneously along all the breast tissue. Maybe emphasize in the upper part in order to lift breast up, but we need to fill in like a multi-layers.
Yes,
Yeah.
the multi-layer or multi-fan technique is very important, especially in the breast. When you imagine you have a subcutaneous layer, okay, then you have a gland. The gland is mixed with fat, and then you have another layer between the gland and the muscle. So you can even fill into the muscle. Even this is possible in the breast. I would say this is a more advanced technique. I would do this later on if you need additional volume because it's more painful and more traumatic. But it's doable, and compared to gluteal augmentation, where you should never inject in the muscle. So when you do gluteal augmenting with fat, you should only inject under the skin. Because if you do a deeper infiltration, you may have a lot of complication when it comes to gluteal augmentation. But in the breast, injecting even deeper layers is very safe. You should not inject into the gland. This has to do with radiologically safety, because some of the fat cells will have an apoptosis, they will die, leaving scars and leaving basically calcifications, which afterwards, for people who are not trained, good radiologists can make the difference between micro and macro calcifications, but people who are not trained may get confused. And the second thing is, the gland is very rigid. It's not a good recipient site for the fat cells. So you should start with a subcutaneous layer, and then you can go below, and then we'll see this today. You get a quite good, normally quite good result regarding this. Are there any more questions? Yeah, please.
Oh, sorry. Does a different side of donor fat side contribute to the survival rate of
It's a question which is very discussed in literature at the moment. There is no scientific concluent answer to this. To be honest, no study could show a better survival from a certain rate. There have been some studies who said that storage fat coming from areas like knees, inner knees, for example, where it's a very stubborn, persistent fat, or a lower abdomen has a better survival rate. But they couldn't. This was not, in my opinion, a very clean study from the study design. And if you would put this on a scientific level of being at least a level 3 evidence-based study, it would not fit. You know, it would not give you an answer. What my answer to this out of experience would be very simple. I don't think that the survival rate is really different regarding site when it comes to body fat, being it from the leg or from the abdomen or something. There is confusion to it because sometimes the quality of the fat that you harvest is different. That means you may think you harvest the same amount of fat, but what you harvest is more fibrotic, and so you have less survival. For example, fat from the back or from the hips has, in general, as patients, when they lose weight, gain weight, there's a state where the area has a lot of fibroblasts working. And so areas like the hips, for example, where you extract the volume, where you think it's the same amount like from an inner thigh or knee, the concentration of pure fat cells is less, so you may think that the survival rate is lower, but you just had initial less fat cells in your suspension. I think this is more important. And one thing what I try to do, because I believe there's a difference in this, in the response of fat receptors, when I do facial treatment with fat, if I have a patient who has enough of fat in the facial area, that means in the neck or everything, I try to harvest the fat from the face, because I believe in the fact that facial fat has different receptors than body fat, because when we look at how people lose weight, the distribution between facial weight loss and body weight loss is different. So there's a difference in response. I use a slightly modified Klein solution in the science of being. You use lidocaine. There are different concentrations which people use. If I use it as a standalone solution for patients who don't have any anesthesia with it, okay, I normally use around, depending on the percentage what you use, but I go to 35 milligram per kilogram body weight. Okay, so you can calculate on the total of the liposuction tumescent solution you use, or you're planning to use, and then you can go to 35 milligram per kilogram. You shouldn't go higher due to the toxicity of lidocaine. If you go lower than that, you may have a patient who's not completely comfortable, okay? Yeah, this is a meeting we do. You're all invited to come if you want to come next year to Spain. Apart from this, if we don't have the choice if we do it in local anesthetic. If you do a patient in general anesthetic, for example, what I sometimes do, I take the lidocaine away because we need to be aware that every local anesthetic, due to their configuration, has cell toxicity. So a former colleague of mine made a great study on checking the toxicity levels on the viability of the cell yield of different adipocytes concentrations, and lidocaine is within the ester local anesthetics the less toxic, but all of them have a certain effect on cell viability. So in a general anesthesia, I leave the lidocaine even away if I do fat transfer, not for liposuction, but if I do fat transfer, okay? And if not, I use adrenaline, 2 ampoules, okay? And bicarbonate.
We like to move on to the facial or the micrograph or the nanograph thing, fat. So in terms of the survival, there's still so many things to discuss. The donor site, how to do, or how the fat graft that you inject, re-inject into the tissue, in that small amount, does the stem cell is working, or the former fat cell that is existing. So there's still 2 big theories, that the survival is both the fat cell, the mature adipocyte.
If you have fat, and if you're interested to do some facial treatment as well, it's very good to know that facial fat grafting is a very, very good adjunct procedure. In the same way, if we gain the facial fat, the fat we use for the breast, you can use it for the face. Important is that you know about anatomy, okay? We have facial fat compartments that age in a different way. Some age earlier, some disappear earlier, and some disappear later, which adds to the point how it changes and how we age. So you can then use fat to retreat and refill, and fat is not only, like he said, a volume filler, but it as well with a nano fat, it can make the skin overlying better, okay? So these are typical volumes which you can use in different areas of the face. I don't know if anybody of you has experience with facial fat grafting, but I'm going to show you here a little bit a trick. When we go here and see at the aging, she's a very good example of facial aging. You can see the areas which losing first. So there are nice publications from Rorik and from Psoa which showing that the area around the eye is one of the first areas losing the fat. So I'm showing you a little bit, this is a live video, I think for you is the most important thing, that by using fat without surgery, and so it's maybe interesting for you as well, you can do very comfortable in a patient when you do good facial blocks with local anesthesia, you can do this treatment very pain-free. Here, I'm basically treating the peri-orbital area and the temple area. So you have to be aware that deflation is a very strong argument of aging. And when we have deflation of the upper temple, the posterior hairline temple, the eyebrow comes down, the temple is hollowing out, and on the other side, the soothe and the roof, which are the fat pads below and on top of the eye, they disappear. So the eye starts to sink in. So you have the teardrop deformity forming out, you have a deflation of the midface, you have a deflation of the malar prominence, and with the loss of this malar prominence, you have a descent of the midface in general, which then will do a malformity of the cheek, nasolabial cheek junction. And what I'm showing you here is a little bit how the whole midface area acts like a pillar. Okay, and this pillar is supporting your lateral orbit and is supporting the fat from your lower eyelid. And so you see with aging, when the midface comes down, the lower eyelid hollows out and the lid cheek junction is pulled downwards, creating basically round eye shape, where when we're young, we have an ovalorate eye shape, okay? So two things happen. We have a soft tissue loss on one hand, and then we have an ongoing bone loss in this area. That means the orbiter itself is opening up because the bone is resorbing. And when the orbiter is opening up, it's widening, and the configuration of the eyelid changes from horizontal to vertical. And here, the next thing, what I'm explaining here is you have a fat pad lying right down here, which acts like a support structure for two things. It is on one hand supporting the deep and mid-face fat pad because it's lying on this nasolabial fat pad, and on the other hand, it is supporting the nose itself. So when the fossa becomes wider, there again, bone resorption, and we have a loss of the resorption. The tissues tend to fall inside. We're starting to get these indentations here. So this area is a very important area as well to fat graft, because you're bringing, on one hand, support back to the nose. On the secondly, you're bringing support back to the lateral midface, and you bring structural support to the lip again, because the lip is basically supported on the way of the philtrum and hangs on the spinal, nasal spine. So you need the nasal spine to be fully projected forward to have a suspension for the lip. If not, the lip as well will turn inwards. So all these areas basically connected. That's good. Let's see what we can here show here.
So for the temporal injection, which plane for the fat graft did you prefer to put the fat in?
Two planes. One plane is on the deep temporal fascia. Okay, that means this is a gliding plane which you can enter with a cannula. We only use cannula, no needles for this. So a cannula injection with a small cannula on the deep temporal fascia plane. And then if I need more volume in the subcutaneous layer, or this layer is full, I inject into the muscle. And you can inject very nicely into the temporal muscle and double the volume if you need to by doing that. The grafting survival rate is very, very good in the muscle because the muscle is highly, highly irrigated. Here I'm showing another very important concept, the mandible. That means
a little bit on the temple.
This is
when you put the interfascial,
Yeah.
up on the deep fascia plane, and also under the muscle or in the muscle, how much volume that you distribute between these two compartments?
I would say 60% on the fascia and 40% in the muscle, more or less. And if I still need more then, without creating too much fullness in the temple area, because we don't want to change the anatomy, you can go to posterior temple, posterior hairline, and you're filling in areas which are not visible on the first times. That means this is a visible area, so at a moment given, you have enough fullness here, and you don't want to make this area fuller. If you want to achieve still more lift for this area, you can fill posterior hairline and you get additional lift to this, which I do normally then with another 4 or 5 mLs posterior hairline filling. Okay, so here's the fat harvesting. What I was speaking before, if I have fat, and I would say in older patients 50 plus, around 80% of them have fat to harvest from the neck. So in those cases then I take the fat, I harvest it, I use a lipocollector, a small one which we have for the facial surgery, and I use facial fat for facial fat grafting. I call those face-to-face fat grafting, okay? And I really do believe these are the blocks, okay? It's very important when you want to do this in local anesthesia that you do good nerve blocks. Supraorbital, intraorbital, mentalis block, and you can do a facial block on both sides as well. When you block all this, even if it looks a little bit bruised, but you see the patient is quite, now the main blocks are done, I do some infiltration in the area, and you can see that the patient is quite okay with that, okay? You will speak later on, see she moves sometimes. It's not a general anesthesia, but it's good. What I wanted to say, a complete under-addressed issue in surgery, but as well in fillers, is normally the gonian angle. So for people who have a weak gonian angle, they will have a premature aging of the jawline very early. So you can do a very simple thing. If you really treat the gonian angle, if you augment horizontally and vertical the mandible, you will achieve a very, very nice rejuvenation of the jawline. This is nanofat. I don't know if everybody of you knows what nanofat is. We have microfat, which are living fat cells. Nanofat are fat cells which we destroy to get to what we call the stromal vascular fraction, which is basically the intercell substance, and which is full of trigger substances for basically neovascularization, for neocollagenation, and showing there are different ways how you can gain nanofat, either over kits, over filters, or you can use this three-way tub, just making the three-way tub, closing it more and more and more and more, and while you pass the fat through it, you destroy it. You make 30 to 40 passages. I can see that some people here are twinging, but I can tell you it is not as painful as it looks. You need to have a good nerve block, no problem. This video, just to tell you, the speed is twice only. It's not like it's 10 times or something. So this is double speed video. Okay? So normal movement is quite quick already. Okay? But this is only double speed. It's not more than that. It shows you how important it is, what he said, the multi-layer concept. You have to be aware where you are, and you start to fill the different layers anatomically in the way how they're missing the tissues, okay? So here I'm the deep layer, I'm on the bone. I'm starting with the deep layer first before I'm changing to the subcutaneous layer. And, but you can see the patient is absolutely in peace. It's a blunt cannula, so the only thing what you have to be aware of when it comes to the vessels, okay? You should, in the planning of how you inject, always visualize the anatomy of the facial blood vessels, and plan an infiltration which is never parallel to the grand vessels. Always go perpendicular to them. The chance then to go into a vessel with a blunt cannula is very low. When you go parallel to it, and especially the big, like the facial artery or everything, it is possible. And there have been described cases of blindness or of even infarctation with facial fat grafting. So you have to be aware that it is possible, and the only way how to so here we can see the change now already. One side I augmented the malar area, and like 4 or 5 cc in this area so far, and we can already see that we get a very, very nice suspension of this area, and we can see the reduction already of the nasolabial fold due to support of this area, because the nasolabial fold is a result out of 2 things: descent of the midface and reabsorption here in the area of the fossa. So it needs to be corrected from both ways.
So the cannula for this nanofat is 25, 6, 7 or?
This is a 0.9 millimeter cannula, inner diameter, 0.9. I use either 0.9 for these areas, and I use 0.7 millimeters for the areas where the skin is very thin. When you do injection in the infraorbital area, you have to be aware that coverage is very, very thin. So if you have irregularities, you may very easily see them. So it's very important when you treat the area around the eye to stay under the orbicularis with fat. It's not like filler. Filler, you can as well go on top of it, but with fat, you have to stay under the orbicularis. And very important as well, you have to inject in a perpendicular way. If you inject in a way like this, and you pull back the cannula, you will automatically, by the sphincter movement of the muscle, create connecting dots, and then the fat cells, by the movement of the orbicularis, which brings them together, when the channel goes like this, they can connect and form little kind of aggregations of fat cells which make lumps. When you come from this and you go back and you go back, they are separated by tissue and they cannot be pulled together. So whenever you fill in the infraorbital area with fat, you should come from here, never from the side. Okay, very important. Here we do mandibular. Mandibular augmentation, you do right through this mass on the bone. Okay, I'm going subs mass there, and and then I'm filling in three-dimensional way. Three-dimensional means I want to achieve horizontal augmentation and posterior augmentation. That means I want to lengthen the angle to the back.
You go below the muscle.
And I go below the muscle, yeah. In the temple area, which we're discussing before, you can see now how I feel it. You have to be very careful. Why do we go on the deep temporal fascia? If you go very superficial subcutaneous there, with a cannula like this, you have a big spider web of veins there, and you're going to end up with a lot of hematoma very, very early. Then you don't see anymore where you're going. So when you go right on the fascia, you're going to feel, when you go through the skin, you go down, you end up, and the fascias are resistant. You glide with your cannula on the fascia. This is no resistance at all in this area, very easy to fill. Then you're below these blood vessels. And the only thing what you have to protect is a sentinel vein, which is the vein which comes out really basically here at the side. You can see with my finger, I'm in the area of the sentinel vein, and I always compress when I'm feeling here, because I basically want to compress the backflow into this venous network, which we have here, while I'm injecting, okay? And once you go from the temple to the mid area, that means you're going basically to mid-pupil line to the supratrochlear nerve. And then afterwards, when this is full, you need to decide if you need to treat the mid-forehead. Because if basically you augmented nicely both temples, but you have as well a deficit on the forehead, you should treat the forehead as well. If not, it will look empty in the middle between the two filled temples. It's a little bit, I mean, for anybody of you who has a waist experience with fillers, this is why I'm showing this to you. This is maybe a very interesting concept if you have this machine one day, that you expand your portfolio from fillers in the face as well to fat. Because I think fat grafting in the face can achieve things which with filler purely I cannot do. And the second thing is what you need to keep in mind, the volumes which we can use in fat are far above what we can use with fillers. So price-wise, what the patient may be willing to afford as well, if I do a full face fat grafting, I may use 60, 70, 80 cc of fat. I will never do this with filler. It's impossible. Even if I do 15 cc of fillers, which is a mega infiltration.
Patients go bankrupt.
Patients go bankrupt, yes. Okay. So here, I show this as well. There is a little vein which is bleeding. Okay, if this happens, you just compress for a minute or something, and it should be absolutely fine, because there's a lot of adrenaline in this area. And while I'm re-injecting a little bit of adrenaline here, I'm just compressing, and then it ends up.
On the direction that you point the cannula to the eyebrow for the orbital rim here, will you go above the frontalis or go deep down?
I go
below?
down because I want to replace here basically the roof. Okay, so I go under the orbicularis, and I have my finger on the orbital rim, and I'm grafting against my finger. So I'm protecting the cannula to not going farther downward anymore. Yeah, so you should always be with your finger limiting the way of your excursion of the cannula. We're going to see this in the body in the same way. You always have to, with the other hand, to be aware where the tip of your cannula is. And your hand is like a sensor, which tells you two things. How far your cannula goes in one direction, and it can tell you as well the layer where your cannula is. So here you see my finger, and you see how I'm grafting. Look, always against my finger, because the finger there tells me not only where I am, but in which layer I am, okay? So this feedback is very important. You cannot have this feedback if you do with one hand. So you need both hands for this. And this is what I was explaining. If you have an emptiness as well in the mid-forehead, you should address this emptiness as well in the mid-forehead. And when we use fat for this, we can augment in this area, and we can as well create, evidently, a spanning effect on the whole forehead. And when we span the whole forehead, the whole brows come up. Okay? That's the idea.
Are there any questions? So I would like to move to the operating room, and then you guys can enjoy your lunch box.
Let me
So
just
or do we have?
I just show this patient at the end, because we are through the video.
มีใครมีคำถามไหมฮะภาษาไทยก็ได้
Yeah. So let it make sense. So this is a patient before the operation. This is a patient a month post-op. Okay, there's still some edema, especially under the eye, because the eye area is the area which is the most sensitive. But you can see the change in the fullness of the whole face. And this is patient 3 months post-op, and you can see it's a brilliant rejuvenation which you can achieve just with fat, no surgery, no cutting, no fillers. So this is around 70 cc of fat which we used in these patients. Okay, good. Thank you very much. And none of fat, yes.
Okay, thank you very much. And save the date, MIPS 2020.